Thanks. Good afternoon, everyone. Welcome to this Gecko session, which is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. These Gecko sessions are held every Wednesday. The chat will be open for questions. If you can just write your questions down, or at the end of each presentation, we'll also take some questions. Ed sends his apologies, Professor Jonas. He's stuck in theatre. We have quite a lot of good stuff going on at the moment. So, and so is two of our fellows who are going to present. But Dr. Sobnach is here, and he's going to present a study that he's doing for his PhD on the natural history of untreated hepatocellular carcinoma in sub-Saharan Africa. And then Pacifico Pai is going to present a case that we are currently managing. Thanks, Sanju.
Thanks, Mark. So I'm trying to share my screen here. Can you see
that? Yep.
Can see it? Okay. So thanks for the introduction, Mark. Thank you, everybody, for being here. We actually thought in the beginning that this would not be an important study, would be something quite trivial to do in our cohort. But in retrospect, we've realized that the majority of our patients actually do not get treatment at critical care. They get only best supportive care. And that does beckon the question of whether, if we are going to give these patients biological therapies or sorafenib, whether their outcomes are going to be better compared to what they are at the moment. So this study is really to benchmark and establish a baseline survival for patients who get no treatment at all. So again, some background. HCC is a major global health problem. It's got an extremely high fatality with an incidence to mortality ratio approximating 1. The highest burden of disease is in our part of the world, in sub-Saharan Africa and in Southeast Asia. And most sub-Saharan African patients with HCC will only get best supportive care. Again, the cause of most of our pain when it comes to decision-making in our setting is the Barcelona criteria. And if we see what our patients present with, advanced disease, C and D mostly, and the options are quite limited. So either they get best supportive care or they get TACE. And as most of you know, we're quite aggressive TACEs. And then the options of systemic therapy, which are currently not available in the public sector. So these are ATEZ and BEV, sorafenib, lenvatinib, or durvalumab. Those are currently, again, not available. We've given it to 1 or 2 patients on compassionate grounds and when the drug was available to us for free. So now if we have to focus on using these biologics, one must really question whether they're affordable and they impart benefit to our patients. So this is some work we've just completed. It's a massive TACE study conducted at Critical Care Hospital. And the interesting thing in this study is we've compared matched patients who receive sorafenib to best supportive care to those receiving TACE. This is the first time this data is coming out. And what it is actually shown is that patients who get TACE, matched patients who get TACE with advanced HCC, actually do far better than those receiving sorafenib or best supportive care. And if we look at the case, if we make a case for TACE, the cost of doxorubicin in our setup for 1 dose is about 800 rands. So if we think about cost effectiveness, TACE remains a very viable option in our setting. Obviously, what we've done is we've stratified patients into high risk and low risk groups based on data that's easily available. So in our setup, we use a gamma GT of more than 800 and the presence of portal vein tumor thrombosis. And we know that these 2 factors are independent predictors of poor outcomes in these patients. So let us just, for argument's sake, make a case for atezo and bev in our setup. Let's say we have to provide this to our patients. The cost is 45,000 rands per month, about 2,529 US dollars today. The response rate in the studies are about 35%. So out of every 10 patients who get these, 3 to 4 will respond. And is there a survival benefit in our setup? We don't have data for this at the moment. So the rationale for this study is to say, well, there's no data for untreated hepatocellular carcinoma in sub-Saharan Africa. We mean long-term data from the time of diagnosis to death. We need this to evaluate palliative therapy benefits, and it's absolutely vital to have this data if we want to do any sort of randomized control trial at our hospital in the future or in sub-Saharan Africa, for argument's sake. So the objectives are to determine the natural history of untreated HCC in sub-Saharan Africa, and then to identify some of the predictors of survival. So we had a retrospective cohort, about 35 years, single center, critical care, ethical approval. Only patients above the age of 18 and must have a diagnosis of HCC, either established radiologically or on histology. Fibrolamellars or mixed cholangio HCCs were excluded. We went back to our paper records, and also we have a prospective REDCap registry now with about 800 patients to date. We looked at the clinical data, the lab results, imaging data. We then granted scores to the patient, Child-Turco Pew score, MELD sodium, a BCLC, and then we essentially looked at their survival with a Kaplan-Meier and did a Cox regression analysis to look at factors that predicted outcomes. We had 728 patients, of whom about 2/3, 64.4%, received only best supportive care. The median age was 48 years. Again, in keeping with the epidemiology of the disease, close to 3/4 were male and more than half were hepatitis B positive. 96% presented with BCLC and D disease. 69% had multifocal disease, defined as 2 or more lesions. 33%, so a third, had extrahepatic metastases, and 39% had PVTT, and 16% had HVTT. So that's considered macrovascular disease. The median overall survival was extremely poor, 36.5 days. The 1-month survival was 59.8%, 6 months, 14%, 1 year, 7.6%, and at 3 years, only 1.5% were alive. On the 31st of January this year, we closed the follow-up, and at that point, less than 1% of all these patients were alive. So if you look at the Kaplan-Meier, it again shows you that the mortality precipitously increases over time. So at 3 years, you've got 1%. At 1 month, close to 2/3 are still alive. We then did a simple assessment. We looked at the different stages, so people with BCLC A versus D, and expectedly those who had C and D disease performed very poorly. But again, if you look at the 3-year survival of an A patient, there's nobody alive. We then did a univariate and a multivariate analysis. For us, what was really relevant was the multivariate. We found that patients who had poor performance status expectedly did worse. If your AFP was more than 400, you were close to 3 times more likely to die. If your albumin was less than 35, you were 3 times more likely to not survive. And the Child-Turco Pew grade, the MELD sodium, and the BCLC expectedly were also excellent predictors of survival. I think these are very important points because they're easy to calculate, and the tests that show positivity in the multifactorial model are very easy available. So performance status is easy to determine. An AFP level is easy to get, and an albumin level is easy to get. And those can really help you stratify the patients who should be getting some form of therapy. Again, worse survival with extrahepatic spread, multifocal tumors, PVTT, HVTT, jaundice and ascites, high AFP, low albumin, and high INR. That was the univariate analysis. But I think we need to pay attention to the multivariate. So easy to remember: poor performance status, advanced Child-Pugh disease, and high MELD sodium, and advanced BCLC disease all resulted in extremely poor outcomes. So what are the implications for this? It does provide a sub-Saharan African benchmark for untreated HCC. What I probably forgot to mention is that 25% of the patients out of the 728 were from other sub-Saharan countries, sub-Saharan African countries. So Nigeria, Malawi, Zimbabwe, Mozambique. So that's quite representative of what's happening in the rest of the subcontinent. It does guide us to the rational use of expensive therapies. It will inform us on the sample size that will be required for randomized controlled trial in the future, and whether a trial would be beneficial. And it validates very simple risk stratification. So if your patient has very poor performance status and a poor BCLC and a high Child-Pugh score, those are not the patients you should be actually offering biologics to. You should look at people who've got preserved performance status with good BCLC scores, and excellent Child-Pugh and MELD scores. Those are the ones where you should really be giving a chance with the expensive therapies. So I'm going to keep this simple. In conclusion, untreated HCC in sub-Saharan Africa is equivalent to a rapid decline and poor long-term survival. To date, I think what still works is early diagnosis and hepatitis B prevention using public health strategies. Cost-effective palliative care strategies are what we need in our environment. There's no sense in giving therapy that costs $2,500 a month, doesn't grant you a survival of more than at least 3 months. And to date, this is the largest sub-Saharan African untreated HCC data set that will soon become available in the literature. Thank you very much.
Thanks very much, Sanju. Are there any questions? If you do have a question, either put in the chat or raise your hand. Don't see any. All right. Sanju, I have a question. So, I mean, I see that there was, I mean, it wasn't what the topic was, but there were Child-Pugh, there were BCLC A patients and B patients who weren't treated. Was that mostly in the earlier part of the study? Because, you know, like our whole big thing is now to have screening and to try and pick up patients who are A and B so that we can treat, you know, those are the ones we can actually treat. Like, were there a lot of those patients? How many were there? And was that more prevalent earlier in the study than later?
Yeah, I mean, it was a very small number. It was a handful of patients, less than 10. And that you're absolutely right. That was, we calculated those BCLC scores retrospectively based on the data we had. Okay. So these patients were not offered a massive resection or TACE before resection. We didn't have those then. So that's a good point that probably needs to be included in our
discussion. Fine. I mean, it's interesting to have those patients because, you know, like you wouldn't really be able to get ethics to do a study to get survival on patients who are not treated with like those early stages of disease.
That's right.
Yeah. Any other questions? The other thing, I know that I'm not that involved in your PhD and it's mostly Ed, but I heard you guys talking about the predictive value of other tumor markers. So CEA, CA19.9, and alpha fetoprotein. And we don't routinely do those, but I know that you've got some information on that.
So I think Mohammed looked at it, and the paper just, I think it's on the verge of getting accepted. And what they showed is that they have found this triple positive group. So patients who have CA19.9, for which the bilirubin has been corrected because that inherently increases their CA19.9. We have a high FP and a high CEA do poorly. And it seems like the patients who are triple negative with a normal AFP, normal CEA, normal CA19.9 do extremely well. So it's, but I think what they argued in the papers, they need much more data for that. I think they came up with this concept. Is there such a thing as a triple negative HCC? Like in breast cancer, a triple negative breast cancer is bad news, but a triple negative HCC based on a normal AFP, normal CA, normal CA 98.9 might actually be a good predictor of survival. The other thing we're trying to explore now in the samples we have in the lab is a PIFCA2. So actually, if you look at the Japanese guidelines for liver transplantation, they look at 10 nodules, all must be less than 5 centimeters. And their argument is they use a PIFCA2, which the Asians, I mean, the Indians also regard it as an extremely good predictor of survival. So that might be another very interesting marker to look for us in the future.
And is it the other way around? If all three are high, is that bad?
All three are high is bad. All three are normal is excellent news. It's
okay, so that's something that you can factor into when you're trying to assess tumor biology and
correct.
Yeah, okay. All right, that's interesting. Okay, it doesn't look like there's any other questions. So let's move on to the next presentation. So Pacifico Pai is one of the HPV fellows here in our units at Critisco, and he's just going to present a case that we're currently managing. Thanks, Pacifico.
Let's try and put it up.
Can you see it?
No, I'm not seeing it.
Now?
Yeah, now I'm seeing it, yeah.
All right. Thank you, everybody in the forum. My name is Pacific Apai. I'm one of the fellows. I'm going to present a case that was referred to us from liver, and we had a discussion about it in our X-ray meeting. So this is a 75-year-old male, performance status of 1. He has a background history of hypertension, diabetes, dyslipidemia, and he has been on surveillance for muscle LD. Previously, he had Hodgkin lymphoma that was treated in 2013 and cured. Clinically, previously well, some routine follow-up in OPD with the yearly ultrasound from 2014 to 2023. He lost to follow up his ultrasound last year. On examination, there was nothing remarkable. He's not jaundice, no signs of chronic liver disease. There was no ascites. Investigation-wise, his numbers are up there. He's RVD negative. Screening was done before some years back. Wasn't repeated again, but his hepatitis screen was negative. Tumor markers, alpha-fetoprotein of 4.5, which is normal, and CA 19.9 and CA were not done. In terms of his blood, he has a little bit of acute kidney injury, probably look like this is his baseline. I'm not quite sure because I didn't follow the rest of his blood, but his urea was 7.5, creatinine of 102, and sodium of 138, actually, not 183. He has a Child-Pugh A5. His billets were normal, nothing really remarkable on those blood results, and albumin of 49, INR is normal. So he had an ultrasound, on a new ultrasound. He lost ultrasound last year, so he had a new ultrasound this year. And on that ultrasound, they noted to have a hypoechoic heterogeneous mass. It was avascular. There was no intrahepatic duct dilatation or CBD dilatation. They proceeded to do a fibroscan, and the numbers for fibroscans are up there, KPA of 9.2 and CAP of 304. The normal is between 200 and 250. And he had fibrotic disease F3 with steatohepatitis. So they moved to do a CT scan for him. So he has a pre-contracted scan. You can see there isoechoic lesion around segment 6. And when you follow up the arterial phase, you can see hyperenhancement. It's a little bit of a poor CT scan. I don't know whether you guys can see there, but you can see rim enhancement here in segment 6 and the portovenous phase. And then in the delayed phase, you see the washout of the contrast. So the question is, this patient has non-cirrhotic liver with a liver lesion, and we couldn't quantify it on the LARAT because he doesn't have any cirrhotic liver. So the question is, what's the way forward from here? Should we biopsy the liver? Should we resect him, given that his age is just at the borderline of 79? I mean 75. Thank you very much. Back to you, Prof.
So thanks. So there's a few. I think we need to have a bit of a discussion about this and why we're wanting to talk about it. So as everyone probably knows, the LIRAD system only applies to patients who have cirrhosis. So in this patient, we don't really have evidence of cirrhosis. It doesn't, although he's hepatitis B positive, he doesn't appear to be cirrhotic, and he has very well preserved liver function. So if he had cirrhosis, then it would be a LIRAD 5 lesion. So that raised some discussion at the radiology meeting. The one thing that you didn't mention, Pacifico, is that patient did have a FibroScan.
Yeah, I mentioned it.
Oh, sorry.
Yeah.
Sorry, what did it show? Sorry.
It's 3. FibroScan is 3, which shows it's
F3.
hepatitis. Yeah, F3.
Yeah. So I mean, F3. You know, I must say I don't have a lot of experience with deciding on resections based purely on a FibroScan, but my understanding of F3 is that there's quite a significant amount of fibrosis. So, it's not absolutely clear to me at what level you can now say the patient is cirrhotic and you can start using the LIRAD system. So I don't know if there's any comments from anyone else, but we decided that we're going to biopsy the lesion. We'll go through and it'll be done percutaneously through a cuff of liver, and it'll be a plug biopsy. So the radiologist will inject glue to seal it. And then we thought we might as well also biopsy the left side of the liver just to see what it looks like histologically. And then we'll probably also do a gastroscopy to see if there are varices or to suggest portal hypertension. Although the platelet count is not low, I don't think he has a big spleen. And then we'll have to make a decision then on whether we progress to a resection or not. It was just that single lesion.
Yes, the lesions are 2, segment 5, segments 6 and 7, almost the same size.
I didn't see the other one.
I reviewed the scan and I saw it.
Okay. So but when you were showing it now, so just show us where the other one is.
It's not on this one
Oh,
because
you can't see it.
Yeah. I didn't write.
So like it depends also, it makes a big difference, what volume of liver we're going to resect. If it was just that one lesion, wouldn't be so worried. But if he needs a formal right hepatectomy and he's got a lot of fibrosis, then we'd be worried. One of the options would be to do a portal vein embolization if he needs a right hepatectomy and a hepatic vein occlusion, and see how much hypertrophy you get. Because if there's significant hypertrophy with that, then that suggests that you're not going to get liver failure. Any comments?
Mark, the other option is to do TACE.
Yeah, no, we could do a TACE anyway. So you could just do a TACE, but it's not a curative treatment.
Yeah, I mean, what would be really, I know it's controversial. A lot of the folks who say tear in their hands, Turkish and the Indians say tear in their hands, curative. Even one of the Greek radiologists we met were quite adamant that a good tear should work.
Yeah.
But again, for us, it's either a resection or an ablation, which is not possible, or a transplant, right?
Yeah. So I mean, I think, you could do a TACE if we're not going to resect him. But I think if he's fit and I think it will depend on how bad the liver looks like. and then we could do a portal vein embolization and see how much response there is. The concern is then, can you do does the portal vein embolization affect your ability to do a TACE later? Because now you've got an occluded portal vein, now you want to do an arterial embolization. But we've done that before, and we have never really had a big problem with infarcted liver, especially if the radiologist sort of targets the lesion and uses beads and it's quite a peripheral embolization. Yeah. Any other questions or comments?
Prof, just I have one question. In terms of his management, whether you want to do a TACE or formal resection, given that age, do you take age into consideration in terms of
How old is
operation,
he
or
again?
just the will you take age?
How old is he again?
75.
Yeah, so I mean, obviously, like 75, you got to take that into account. And the other thing I noticed on the CT scan is he's got a lot of calcifications in his aorta. So he's got atherosclerotic disease. So if he's not a good 75, then TACE might be a very good option. And we don't have TEAR available. If TEAR was available, it would probably be a better
Gold
option.
standard. Yeah.
Yeah. And then the other thing would be, if you were in a center where it was available, if you weren't going to resect him and you're just going to treat him with TACE, you could add a biologic, like atezo-bev. That's what would be done in a place where there was lots of resources and lots of funding. Then you could do a combination of a chemo embolization or radio embolization plus plus immunotherapy. So that would be another option. Yeah.
Okay.
If there aren't any other questions, I need to just apologize on we don't have any more presenters. We actually have a liver transplant that's starting now, and a lot of the team are involved in that. So I need to apologize that the other presenters are not here, and Ed also sends his apologies. So I'd like to just say thanks to everyone, and thanks to the ECHO University of New Mexico team and the ECHO India team. Records of this are available on the Gastro Foundation website. Thank you to the Gastro Foundation, the presenters, and the sponsors. And next week will be on patient blood management. Thank you, everyone.
Thank you.
Thank you.